This is the Tox Course Podcast. Hi, and welcome to the Tox Course Podcast. Andy Buck here. Look, today we've got an amazing guest. He's a colleague of mine. I work with in Melbourne. His name's Martin Dutch. He's an emergency physician who has carved out a bit of a niche for himself in what's referred to as mass gathering medicine, or as I like to call it, festival medicine. It's a bit cool. It's a bit niche. Martin is part of a multidisciplinary team that provides very high-end medical support to patrons and staff at large music festivals, often held many hundreds of kilometres out of capital cities in Victoria or outside of Melbourne, in rural and remote isolated settings, resource deplete. But Martin and his colleagues have created a fantastic resource where they take a high-end medical team out, set up essentially a field hospital and provide high-level medical care to sick people at music festivals. Obviously, there's a range of things that present there, from quite boring, simple medical things to very, very sick, critically unwell, peri-arrest toxicology patients, essentially, who are suffering the effects of often multiple stimulant drug ingestions. And we delve right into some details in this episode about how to manage these critically unwell tox patients, in particular, the extremely hyperthermic, the very hot serotonergic / sympathomimetic toxidrome patient who is on the verge of death. And we'll delve right into it now. This is a fantastic chat. Goes for a while, so feel free to grab a drink, pop your feet up, or if you're driving, have a listen. I think this is full of pearls from Martin, who is a really an expert in this field. Welcome, Martin, to the Tox Course Podcast, and thanks for joining us. And maybe you just want to introduce yourself quickly to the listeners.
Yeah, hi, my name's Martin Dutch. I'm an emergency physician in Victoria, Australia, and I volunteer my time working outside of hospital at mass gatherings.
For the listeners that don't know, Martin and I sort of trained together early on. We're sort of a similar era in the emergency medicine scene. We've both gone off and developed a few niche areas of interest, and Martin's got a really interesting niche area of medical interest that I'm kind of fascinated by. And we do work together, slight conflict declaration, we do work together in the same emergency department at the moment. So I hear little snippets about what Martin's been doing, and I've really fascinated by it, and I think it's super interesting. So that's why I invited Martin on. And so, Martin, maybe we'll just jump into this then. You've found this niche to do with mass gathering medicine. I like to call it festival medicine, which has become a bit of a thing over recent years, and actually has been getting quite a bit of publicity due to people overdosing or getting quite unwell after ingesting certain substances at music festivals. So maybe could you tell us quickly how you sort of got into this niche and how you've developed your expertise in this area?
Sure. I've been doing this for more than 20 years, I think, which is a bit crazy. Basically, the area sort of started back in the early 2000s. And the issue was that as we started holding more and more music festivals, recreational drug use became more and more frequent at them. And it was generating a patient workload that just simply having first aiders present wasn't able to deal with. It sort of overwhelmed them. And their appropriate response was to call an ambulance and send those patients to hospital. And the problem became that every time you held a music festival, that would be associated with a large number of patients being transported by the statutory ambulance service to hospital, and that would stress community resources quite significantly. And so it became obvious that what we needed to do was put more higher level acute care resources at music festivals to attempt to manage patients on site and reduce acuity to allow a less impact on the broader community.
And do you think the sort of the landscape of either the drug use or the festivals or and by inference the workload has changed over those 20 years? Or is it sort of similar stuff you're seeing?
No, absolutely massively changed. I think that the sort of early 2000s for us was a really big explosion in GHB use, and initially that was consumed in isolation, and subsequently, and so that was a relatively easy toxidrome to manage once we got used to GHB being a relatively easy thing to manage, the initial sort of response was you intubate these patients, but then we realised that actually no, most of these patients could be managed safely, on a stable side position with appropriate monitoring, and they'll just wake up. But subsequently, what's happened is alcohol companies have become a co-sponsors of these events, and co-ingestion of alcohol and GHB and soiled airways and that sort of thing is added to complexity. And then the use of amphetamine-based drugs has become far more prevalent. And in today's sort of music festival environment, nobody's really taking a single agent. Everything is polypharmacy with many sort of what I'd call traditional recreational drugs, but also emerging novel psychoactive substances.
Is that by intent or by accident that people are consuming mixtures? Do you know?
I don't. That would be by intent. People all, and if they can't declare the drugs, their friends come and tell you what they've taken, and will list half a dozen different ingestants over the day.
Wow. Yeah, right. So it's not just retrospective realization that maybe there was something mixed into the batch of G or something mixed into the powder that they took, but people really just going for broke and taking lots of different stuff.
Absolutely. It's mind-boggling. Like we do toxico surveillance of our sicker patients, and
is that through the EdNav?
Yeah. So we can talk about that in a bit if you'd like, but we can look at the type of drugs that are ingested, and polypharmacy is the rule rather than the exception.
And so when we're talking about this mass, like as far as mass gatherings or these festival things, what sort of sizes of gatherings are we talking about? What's your sort of size of the average festival you work at? How many people attend?
Probably, it's a good question. Probably 10,000 would be a reasonable number, but of patrons. But there's certainly festivals that go up to sort of 35, 40,000, and in our local area, there's certainly one promoter who's expressed plans to grow their festival to 50,000.
Wow.
Individuals.
So these are like, creating a small to medium to large size country town out of nowhere for the weekend, isn't it? I mean, that's a huge number of bodies moving around. And,
Absolutely.
if you just took your average country town, I don't know, Sale or Colac, someone's got 13,000, 14,000 people, just think about what would happen in their ED on a Saturday night when people aren't going there and taking loads of drugs. They'd be busy. And you must see a range of stuff coming in besides just the drug stuff.
Yeah, so probably half of our presentations are alcohol and drug related presentations, and the other half are just a wide variety of different medical problems and misadventure that people get up to.
Yeah. But it must keep you busy though.
Absolutely, yeah. We can see literally hundreds of patients in a day at these events.
Wow. We'll go on to talk more about that in a minute. And obviously there's a lot of logistics involved then. If you're setting up to manage that many people, you must need a fair bit of kit and logistics and supplies and transport and comms and power and all those things. What are the sort of key logistical things you have to organize? Like, what are the main areas of stuff you've as a planning operation and then implementing? What sort of are the key things you need to bring in and set up to do this?
Yeah, so we sort of set up a small field hospital, and that'll often have somewhere of the order of 10 to 20 beds inside it. We'll have several resuscitation cubicles set up. Each one of them will have the sort of things that you might expect in a resuscitation cubicle at work. Certainly, we have fully tricked out monitors, 12-lead ECG capability, capnography, 3-lead pulse oximetry, invasive temperature monitoring, that sort of thing. So there's the medical equipment, ventilators, oxygen, all of our medication cache, IV access. We do plastering, procedural sedation, joint reduction, that sort of suturing, that sort of jazz. But to That's just that's the medical component.
And you obviously, do you have an ultrasound or any other imaging?
Yeah, so we have access to point of care ultrasound, and we have point of care blood testing for using an iStat machine.
Yeah, right.
So that's the sort of medical infrastructure. But then,
So pretty much just to clarify for that, Vibble, so it's sort of full resus capability, really, isn't it? I mean, that's sort of the
yeah,
pointy end. Obviously, maybe not the majority of what you see, but like you have that capability to intubate people, provide hemodynamic.
stick them on a ventilator, keep them asleep,
Yeah,
and work out what the hell we're going to do with them at that point.
yeah, which we'll get to in a minute. And so, what are the other sort of things? Obviously, that's just the pointy end, the medical stuff. What else is happening in the background? What are the sort of other logistical things you have to do?
So from a practical perspective, when you get 10,000 or more people rocking up to a sheep paddock outside of a tiny country town, which is sadly often where these events are held, the first thing that falls over is the local mobile phone or cell phone tower. It just can't handle the number
Load.
of the load, and so nobody has any signal. So all of your communications just disappears, and that can be really interesting. If I want to ring up a local hospital and say I'm sending somebody something or I've done something unusual, being able to get a phone number out can be challenging.
So, how do you manage that?
So we've got a communications command bus that has sort of Starlink connection to the outside world, and then we broadcast that over a local wireless Wi-Fi network, which means my mobile phone can do wireless calling, so I can basically walk around my field hospital and place a phone call, use the internet, use a computer normally, send an email, ring up a local emergency department, that sort of thing, whereas the rest of the community there are struggling from that sort of thing. But also we'll have crews that will go out into the campsites if it's a residential, because some of these music festivals go on for multiple days and people sleep on site in tents. And so we'll have crews that are going out and retrieving people, and all of that's coordinated over a secure radio network.
And how do they get around the site? Have you got your own vehicles or?
Yeah, so combination different things. Yeah, so standard sort of stretcher ambulance type vehicles is how you can get around some areas, but we also have modified all-terrain vehicle buggies that have a stretcher that can sit on the back of them, and that's how we and feet. That's always good, walking around.
Yeah.
So it's how we get people around, wheelchairs, that sort of thing.
So it's multimodal.
Yeah, absolutely.
Yeah, yeah. And what do you do for like electricity and water? Is there generators or?
Yeah, so we have a dedicated logistician on our team. They often know the electrical requirements a lot better than I do, but I don't know, 20 kilovolt generator or something like that.
Yeah.
Will power the place. We have power failures from time to time. Heating and cooling is really important.
Yeah.
Often these are in the middle of summer. So when we started doing this, it was pretty the environmental temperature inside the pavilion tents that we use was often quite unpleasant, but we've got better at working with event organisers to provide us with heating and cooling that's sufficient.
I think there was a well publicised festival over the recent summer holidays here where there was fairly extreme daily ambient temperatures, so that'd be pretty important. And if you're inside a tent dressed for work trying to resuscitate people, you obviously get quite hot. And I guess that's probably something else that's changed over the years, isn't it? I guess the technology to support this sort of thing. 20 years ago there would not have been a Starlink bus with a satellite connection and Wi-Fi, would there?
Yeah, no, that's been a very significant improvement in our ability to communicate with the outside world. We've always been able to use our local radio network to communicate between ourselves on site, but the sort of satellite communication capability has been transformative.
Yeah, and so what other organisations do you have to liaise with for the logistics here? Because I imagine I think there was, again, this well-publicised festival that got cancelled mid-festival in Victoria over summer. It was due to the fire risk. Was one of the big things because it got too hot and it was a bushfire-prone area. And obviously there's police and the festival organisers. Is there anyone else you sort of have to liaise with, or what's the sort of the process of working with these other organisations?
So basically, as you said before, it's like running a small town. So everything all the services that you need in a small town, you need to have at a major mass gathering event. So fire, police, security, ambulance to transport patients off site. All of these different, and they tend to, the way that it's managed is they tend to all, a representative of them sits around in a room, sort of an emergency management team sit around. And so if the cleaning team, if there's a cleaner who identifies somebody who's collapsed at, toilet number 36, they can radio up on their radio to the head cleaner who's sitting in the room, who can say, oh, there's somebody unconscious in sort of toilet 36. And they'll stare across to one of our representatives who will then enter the job into a computer, and we manage all of our jobs via a local network of computers where we dispatch resources to attend the job. So it's communicated centrally through a team that sit round a table and chat with each other about what's happening real time, 24 hours during the event.
Wow, that's an amazing level of process going on in the background. I don't know if your average punter who's out on the dance floor having the time of their life would possibly realise that there's that many people with their welfare in mind hovering in the background. That's I think it's amazing.
It's pretty cool.
And I guess also it's good from that sort of quality assurance point of view as well, that you've gotten to that degree of organisation and documentation. And
yeah, I mean, there's some variability in the competence of event organisers, but we like to hang out with event organisers who are competent and run a slick outfit, because it just makes doing our job easier.
Yeah, and I guess we can move on and talk more about the pointy end of the medical stuff now. And I guess that's, I think it's important that you guys have that level of sophistication and quality assurance and that degree of interaction with the organisers, and potentially picking good organisers to work with, because when this stuff goes wrong, it goes really wrong, doesn't it? I mean, when if we want to talk about the serious side of this, if a young person goes down at a festival, there's been deaths, multiple deaths, and these things end up in the coroners, sadly. And it's pretty serious. And I guess it's important also potentially for the families and things, I guess, to know that everything that could have been done was done for their young person. So on that, I guess let's get into it now then, about the actual tox stuff. And obviously there's just maybe someone who's smoked too many bongs and having a bit of a spew and isn't too bad. But what's the sort of the more serious end of the spectrum stuff you see, and how do I guess let's pretend a little scenario, like how does someone who's gone down on the dance floor or in their tent in the back of the car park tent city, how do they get brought to your attention? You mentioned maybe a cleaner finds someone in the toilets. What sort of otherwise do people get identified? Obviously a friend or someone notices someone struggling.
So by far the most common thing is that a friend will identify that one of their friends is unwell, and we have mobile crews that move through the event who can be flagged down. But there's all of the other employed people at the event, so whether it be usher type people, security, people working behind the bar, lots of different places and individuals that have their own jobs, but generally are all connected via portable radios and have line managers that they can escalate problems to. So the good thing about being at a mass gathering is that for most people, most of the time, it's a very public place. The crowd density is high, and so it's difficult to have a major problem without somebody else noticing that you're lying on the ground when you should be standing up.
I guess, and there's the odd case you hear about someone who sort of wandered off into the bush maybe and gets lost for a while and doesn't get found for a while. But I think that's kind of reassuring, isn't it? By the sheer numbers, you're likely to get found. And so someone will radio, your crew might go out, and we don't need to go into specific cases, I guess, but I remember you telling me about a recent case where there was, someone was quite sick out in the tent city somewhere. And what sort of things do you need to be able to do, or can you do, or do you do to people as a sort of, pre-hospital, I guess you call it, pre-transport to clinic? Do you have to get to too interventional in the field, or do the basics and get them out? And what are the sort of challenges you face doing that sort of thing? Obviously, I'm guessing most of this happens at night in the dark in a pretty tricky environment.
Yeah, so it can be at night, it can be during the day. The environment is always difficult. It can be, if it's, at an actual stage, it's deafeningly loud with strobe lighting, with poor crowd control, which adds to the technical challenge of accessing the patient, finding them, that sort of thing. So we have a mixture of different crews at the events, from sort of first aiders that have a few extra tricks that they can do, and then we have APRA-registered paramedics and nurses. And so if we had sort of an unconscious patient, we would send the closest crew, which is likely to be a first aider as they're thickest on the ground, but we'd automatically back them with probably a volunteer, one of our volunteer paramedics crews to attend. And they do their initial assessment. And probably the thing that sort of the presentation that worries us the most would be a drug-induced hyperthermic presentation from amphetamine-based agents like MDMA, ecstasy. And so potentially these patients are either psychomotor agitated in that standard way that you'd find a agitated patient in the ED who's presenting ice affected, or alternatively they're reduced GCS lying still, but they're stiff as a board. And those are the really sick people. They're the severe serotonergic patients. And our crews, our paramedics, will initially commence some cool normal saline, some IV access if they can, give some midazolam, and attempt to take them back to the medical tent with sedation.
I think let's delve into that, because I think that's really the pointy end of this, isn't it? This is the sort of the worst case scenario. You get a young person who's taken too much sympathomimetic / serotonergic agent, and they're getting into that rigid, altered conscious state, hyperthermic situation, and it can be a bit of a runaway train, can't it? Once people get too hot, and that's probably the main thing, isn't it? Is the temperature control as well as the other elements. So, and I know we've talked a bit about this recently about the cardiovascular and rhythm things you'll see on the monitor, the temperature management, the airway management, and just the general supportive stuff. When someone, you've got someone who's cooked on MDMA, they've been transported by your paramedics and they come into the medical centre, what sort of variables are you looking at from that point of view to manage, and what sort of things do you see with the really sick ones?
The first thing when somebody comes in, it would be the same sort of things that you do in a resus room. We want to try and get them on a monitor and get some initial sort of primary survey, sort of vital signs of what's going on. And so if we just run through things in a sort of structured way, their airways often uninstrumented at this stage. They're spontaneously ventilating. Often their ventilation rate they're quite tachypnic. They've got an underlying metabolic acidosis, and they're really sort of Kurzweilian, blowing that off as much as they can.
Sorry, you mentioned this to me before about how important it is for people to recognise that specific feature because of the degree of acidosis, that if you then intubate them on a rest rate of 12, things can go downhill very quickly. So I think that's just a key point for people if you see one of these patients to not gloss over the rest rate, is it?
Yeah, so in the same way that you would have a different ventilatory strategy for a DKA patient, you'll need a different strategy for the patient with the profound metabolic acidosis who's got a sympathomimetic overdose.
Do they have much trismus, do you find, from the airway point of view? Often
trismus can be absolutely a problem, and it's not always responsive to a little bit of midaz IV. But I'll just paint you the picture. So we've got maybe somebody with a bit of trismus, certainly working hard to breathe. The heart rate is often impressive. So heart rate's generally about sort of 190. And it can either be narrow complex or broad complex, and that'll freak people out, because the broad complex, you go a regular broad complex tachyarrhythmia at 190. I think we learnt that as VT at some stage, but not always, because people are so hot. You can get aberrant ventricular conduction, so it can be like a VT mimic we'll get back to that. And the GCS is often maybe groaning, eyes not necessarily opening to noxious stimuli, and often sort of significant tone. The tone is disproportionately increased in the lower limbs, but you can get a sort of extreme version where the tone essentially takes over the whole body and everything becomes stiff. So from the feet all the way up to the jaw is stiff, and these patients can present almost like that classic sort of risus sardonicus patient that you see in textbooks with tetanus, where their back is arched and they're completely stiff. All of our crew will assess for clonus, inducible ankle clonus, and we'll often have a look at the eyes for ocular clonus. In the sort of moderate serotonin syndrome, clonus will be present in the ankles, but in the most severe form, the sort of lower limb stiffness and plantar flexion is so impressive that you can't physically overcome it to push the ankle backwards to induce the clonus. So these people are properly stiff, and these people are sort of actively dying. I think it's reasonable to say. The other thing to say is that in terms of temperature management, people be familiar with tympanic thermometers. They're easy to use, but they're most, like all of the ones that I'm aware of, have a maximum temperature that they can take, which is about 43 degrees. And if you see high HI on a tympanic thermometer, it generally means that your core temperature is above 43 degrees.
Which, again, generally not compatible with living very long at all, is it?
No, these people are dying. And I think that we've got access to, we can swap to some invasive esophageal temperature probe monitoring, and the hottest patient I've had that survived is 45.1. Which
that is cooking,
which is pretty impressive. But we would classify anyone with 40 degrees or above as critically unwell that needs urgent intervention.
We're going to even just pull this apart a little bit. I guess if for people that haven't really thought about this or don't know about it, what starts happening when you get over that 40, 41 degree mark is you actually start denaturing cellular wall and cellular organelle proteins, so that your cells are cooking and denaturing and starting to just not have, well, I guess have irreparable damage, isn't it? The cells are cooking and they just stop working. That's multi-organ sites there. So you can imagine.
I think of it like cooking an egg, Andy. It's you've got the white of the egg, and then you start cooking it, and it turns white. There's no one cooking it. And I think the way I think about this is a little bit like all thermal injury. It's a combination of, yes, how hot you get, but also for how long you're exposed to that heat. So the sort of area under the curve sort of concept. So once you start getting over a certain temperature, it's a time critical emergency to lower the patient's core temperature.
Yeah, and it's really sort of minute by minute, isn't it? Every 5 minutes it goes by that you're not lowering. I think that cooked egg analogy is really good, that if you leave them maybe at a slightly lower temperature, 40 for half an hour as opposed to 42 for 15 minutes or something, they might have equal areas under the curve and get equal amounts of damage. So yeah, just the lower the temperature for the shorter the time, the better. So let's delve into that then. So you're in your field hospital, not in a fully stocked quaternary ED where we normally work. How do you cool these people down?
I think the first thing that's really useful is intravenous access. So we'll go and place two 18 gauges in the cubital fossas. That's often more difficult than what you would expect, because these patients are often either stiff, or before they become stiff, they're flailing around. They're profoundly diaphoretic. So, you've got to find a vein, stick something in, and then work out how you tape it down so it doesn't fall out. Often we use crepe bandaging over the top of your standard sort of IV access approach. And then what we keep 4 degrees Celsius crystalloid in big eskies full of ice. that we pull out and we stick them on a couple of IV poles, and everyone sort of gets 2 litres of 4-degree Celsius crystalloid running. And what we're doing with that, I understand there are a few different views out there about the utility of cooled saline. There's a few different things that's good. First of all of these patients tend to be intravascularly undervolumed because they've been hot for a while now. They probably haven't been drinking enough during the day anyway, and so they're all a bit underdone. And when you're underdone, you peripherally vasoconstrict, and if you've not got blood flowing peripherally, you've got problems with your ability to lose temperature through radiation. So just revoluming these patients is a nice thing to do to help them, assist them to lose their own heat. But the other thing is that your actual thermal mass calculations, it does reduce your core temperature. Now, if you do the thermal mass calculations, it's only by, 1 or 2 degrees, but 1 or 2 degrees here can be massively useful.
Some people do argue about that and go, oh, if you've got a bathtub of 40-degree water, that's whatever, call it 45, 50 litres of hot water, and you tip 2 litres of 4-degree water in it, you're not going to make any difference. But like you said, even small changes for these people make a big difference. And there is that other element, the other physiologic element of revoluming and allowing people to dissipate heat.
So that's certainly that's standard for what we do. In addition to that, we're giving midazolam intravenously, and the purpose of midazolam is really to allow people to stop flailing around. But in addition to that, much of the heat is generated through skeletal muscle tone and contraction. So what we're titrating our midazolam to floppiness, for want of a better term. Once the patient's not stiff, then they've had enough midazolam. To that end, we start off sort of 2.5 to 5 milligram increments is pretty classic, but it is nothing to be using 20 to 30 milligrams intravenously of midazolam on these patients. And it's going in reasonably quickly because we sort of do something, see if it's worked, and then repeat it in a very, very short interval. But for the patients who are over 40 degrees, basically our plan is to RSI those patients. So when you get really hot over 40 degrees, the plan is to RSI. But before we do that, for the people under that, we'll also be doing ice pack cooling. We apply ice to the axilla and to the groin, and a practical tip is we obviously strip these patients out of their normal clothing, but I keep the undies on because the undies are quite useful to hold the ice packs in, so over the femoral triangle. So half of the ice pack is sitting in the underwear and the other half is on the anterior thigh, and it gets held there nicely.
That's a nice combination of maintaining some semblance of dignity and practical cooling tip.
You do what you can do. So now we've got bilateral IV access. We're giving some cool fluid. We're revoluming the patient. There are ice packs to both axillas, groin, sometimes the neck, and we're trying to midaz them to floppy status. Sometimes, if your temperature's 38, 39, you do all of that, you can arrest the cooking process at that point, and you'll notice that temperature stabilizes and then slowly comes down, and that's great. But for the patients who are either refractory to those interventions or start with you with temperatures of 40 degrees and above, those patients really just need to progress to RSI. They're the people who are really actively dying.
And have you got any tips for that RSI process in these people? Because obviously they're the really thin end of the wedge, critically unwell people. And I mean, on the ETM course for trauma, I have this mantra about resuscitate before you intubate. And obviously you've talked a bit about that, about some volume and things, and considering the respirate. Is there any other sort of practical tips for intubating these people? Because it's a time of, you're introducing some possibly negatively inotropic vasodilating drugs into the system. you're going to stop them breathing for a period. Obviously, you want it to be fairly slick and smooth. What's your sort of process for tubing these people?
Yeah, sure. So I think what I would say is the right approach is the approach that doesn't result in you killing the patient. And I say that because this is treacherous, and there's many different ways that these patients, this intubation can go poorly. Just to sort of recap, these patients have often got huge minute volumes. They've got a heart rate of 190, a blood pressure of 70 systolic with vasoplegic shock, and you're needing to sort of emergently intubate them. The purpose of intubation here, I should just point out, is different from the sort of standard reason you'd intubate somebody. We tube people for airway protection or for respiratory failure. The indication here is for intubation is really a side effect of the primary goal, which is urgent skeletal muscle paralysis. Obviously, if you give some people some rock, you probably also need to manage their airway and breathing at the same time.
Yeah. So it's thermogenesis reduction, stopping them making heat.
Absolutely. That is the indication.
And then your goal is to just keep them alive while you're doing that.
Yeah, correct. And so the first thing is to say is that for some of these patients, I've done standard, very boring RSI like we'd normally do. I've often been a bit worried about use of succinylcholine in these patients because I'm worried that that there's the potential for hyperkalemia, and you don't always have time to do a point of care test for it. That being said, when we have done point of care tests, hyperkalemia is often rare initially in these patients. It's unusual, but I have had hyperkalemic patients by the same token. So sucks is something that I would probably steer away from in preference to high-dose rocuronium.
And I guess from a practical point of view as well, you don't want these people sponventing in the next 5 minutes anyway, do you, that you would get with sucks? You don't want them starting the paralysis to wear off and start.
No.
The whole point is to keep them still for as long as possible.
Absolutely.
Can I ask as well, Martin, just about sedative doses then as well? Because this, for people that aren't familiar with this, I guess this probably isn't your standard. I mean, no one uses thiopentone anymore, but the old thiosux or the old slugger propofol, and a 1.5 milligrams per kilogram of propofol is probably not going to be the best for these people. So what do you use? I mean, and then there's people talk about the potentially avoiding drugs like ketamine in the sympathetically activated person because it can have that sympathomimetic effect. Do you have a preference or a nuance that you do for this? Is it just dose?
So the first thing is, stare at the patient in front of you. They've probably already had a heavy dose of midazolam as part of your lie there and try and stop moving approach.
Yeah.
So they're probably, and then the other thing is that they're already sort of cognitively obtunded, and the purpose of your sleeping medication, whatever you choose, is to reduce cruelty and make people comfortable while they're being mechanically ventilated. So practically a lot of the sedation is already on board with these patients. So I tend to use like tiny 30, 40 milligrams of propofol, a tiny amount, and then worry about ongoing sedation post-intubation. That's the standard RSI approach. There's a situation you can get into where you've used the midazolam to try and make people floppy, and rather than achieving floppiness, all you've done is blunt their respiratory compensation mechanism. Now, that's embarrassing when that happens, and we've seen that a few times. And so I've even done things where we've given the paralysis agent, and rather than stuff around placing a tube in a difficult environment, sometimes if we've had to go to the patient, this is in the dark, on the ground, in a poorly lit environment, I've just paralysed, popped down an LMA and hyperventilated them, basically to blow off their CO2 to achieve reasonable oxygen levels, and then secondarily transitioned from an LMA to a standard tube at that stage. I've also tubed these people spont venting previously when I've been too worried that I'm going to knock off their respiratory compensation mechanism as well. So a number of different approaches, and I suppose that the right approach depends on the patient and the environment and the equipment and your assessment at the time.
That really illustrates there's a real nuance to it, isn't there? And if you're perhaps in an ED somewhere or a patient like this gets brought in, obviously, yeah, your average ED doctor is not going to find themselves in that situation you're talking about, in the field, unless they're part of a team doing this and will have that expertise around. But just, I think they're really important variables to factor in and to think about, if you've got someone like this in front of you and you're perhaps not the most confident resuscitationist or intubator. These are often young people on the maxed out from their compensation point of view, and it doesn't take much to just tip them off the cliff. And this is one of these situations where you really want some experienced help around, isn't it? You'd want to get your ED consultant or your anaesthetist or consultant level help before you start thinking about popping tubes down these people, because it could really just tip them over.
Yeah. So physiologically, these are the sickest patients, I think, that I manage. I work with you, Andy, in a big shop. You see sick people.
All the time.
Yeah, but the person who has a respiratory rate of sort of 30 with big Kussmailian breathing, who has a heart rate of 190 and a blood pressure of 70 systolic, an unrecordably high temperature, and that's post your optimization. It's
that's pretty hairy.
Can I say it's sphincter-tightening?
Yeah. Well, I guess that might be a nice point to move on then, and just to quickly just finish up, talk about the logistics of moving this person out of the scene, because obviously you're not going to keep them there all night on a rock infusion. The goal is obviously to get this person out of there to a higher level of care. So what are the logistics around that from a field hospital point of view, and at 4 a.m. with boof, boof, strobe lights and techno music blasting in the background? How do you get these people out to a higher level of care?
We should just talk about sort of post-intubation packaging sort of stuff. These patients will need, obviously they'll need continuous paralysis, so you need to think about that, whether you run an infusion or you'd be very careful about rebolusing, because that's your therapeutic intervention. This is not, failure to have continuous paralysis is failure of the intervention. So you need to continue to run that, and that's probably something different to many of us manage our post-intubated patients unparalysed, but that's not the point here. Paralysis is the point. The other sort of interventions that we've done from time to time is we've done cold bladder irrigation. So sticking in an IDC, obviously if you have a 3-way, that makes it relatively easy to put in some 4 degrees Celsius fluid, clamping it, leaving it in there for a few minutes, draining it, repeating it. It just is another way to try and cool these patients. Covering them with more ice packs, that's the sort of intervention. And at some point, your temperature will come down with those interventions. And then for us, we'll you're in the middle of a sheep paddock, hundreds of kilometres away from something that we'd call a reasonably big emergency department, maybe a hospital with an intensive care unit. These patients end up flying out is the rule rather than the exception in my practice environment. And so we need to liaise with the flight paramedics about whether they come to us or whether we go to them. But often we'll then need to package the patient up nicely and load them into a vehicle and drive them to an emergency helipad to rendezvous with the flight paramedics. And then after you've done that and they're loaded, often they've had a cluster of unusual interventions, and so we would ring the receiving hospital, and the conversation generally starts off with something along, hello, my name's Martin, I'm an emergency physician, and I'm calling you from a sheep paddock outside of a town which nobody will have ever heard of before in regional Victoria, and I'd like to tell you about a patient that you're going to receive. So there's often a bit of confusion for a few moments when the in charge receives that phone call.
Yeah, and I guess it is, were I to be on the if it was you calling, I go, okay, it's another Martin special coming in hot, literally. But for those that aren't used to hearing about these patients, you really need to switch yourself on to this very specific sort of toxidrome clinical situation that the person's in, and be mindful of maybe not going, turn off the rock infusion, take the ice packs off, the temperature's fine. Being a bit mindful that this person, while they hopefully will have improved a bit with your excellent resuscitative measures, are still critically unwell when they get to hospital. I mean, these people are going to be looking at days in ICU potentially, and will be hovering on that, 1, 2, 3 multi-organ failure precipice, or well into it by the time they get to you, and often need fairly urgent transfer up to the ICU. And I guess also just thinking about, we didn't really talk about it, but I guess, you'd pick it up on your point of care thing. It might be a bit more obvious, the hyponatremia that people sometimes get along with this, and the seizure complication people get from MDMA, and then other stuff that I know has happened to people at festivals. Not every confused, agitated person at a festival is on drugs. Kids get subarachnoid hemorrhages from sympathomimetic surges, and blood pressure rises and being out on the dance floor dancing. People fall over and hit their heads, or have occult injuries and things. I mean, it sounds like the group you're talking about, Martin, though, is fairly has fairly pathognomonic signs of the rigidity and the temperature and the whole together. But I guess just being mindful, if you're receiving these people in hospital, it's probably not a bad idea to at least scan their brain and make sure that's okay, and plus or minus the rest of them to look for other stuff.
Absolutely. Some of the other things that might be of interest to talk about, Andy, is people often say, oh, well, there's an antidote for serotonin syndrome, isn't there? Cipraheptadine. And so I just have a few comments about cipraheptadine. For me, cipraheptadine is the antihistamines of anaphylaxis. So somebody comes in and they've got anaphylaxis, and they've got wheeze, and they've dumped their blood pressure, and they look sick as a dog. You don't sort of lead with, here's some cetirizine. You lead with adrenaline, and I suppose in the serotonin syndrome, you lead with muscle paralysis in critically hot people. And sure, after you've saved their life, the person with anaphylaxis might say, oh, I'm really sort of itchy, and you go, oh, that's interesting. Here's some, cetirizine. It's really verging on homeopathic intervention, cipraheptadine. It's something you do later on.
It's not the thing that's going to make the difference.
Yeah. If you want to do it, 16 milligrams ground up via a nasogastric tube, but truly that's your last intervention after you've done all of the other stuff aggressively. I think that's a point. The other thing some people talk about is using chlorpromazine, like Actal, for these patients. It's certainly described in a number of the sort of guidelines and that stuff. And my advice to my colleagues is don't do it. It only ends in tears. These patients have you might be lucky, and their blood pressure might be sort of hanging in there. You give chlorpromazine, and you guarantee that you'll make their hypotension unmask itself and reveal itself, and it'll just be if it wasn't a problem before, it'll just be another physiologic problem that you're having to try and remedy at the same time.
And a simple analogy for that is perhaps that's why when we have migraine patients in short stay, we mix the chlorpromazine in a litre of fluid and give it to them, because even those little doses in a healthy person can sometimes just give them a little dip. And if you're really, really hot and crook, and your heart's, you're off the end of your Starling curve, you don't want to be doing anything to unmask the hypotension. Look, Martin, that's a fantastic review of that very interesting and clever niche that you're in, and I think it's a testament to the years of practice you've put into it that you seem to have kind of honed it to a fine art now. And again, I'm not sure your average FACEM or ED reg probably realises there's that degree of care being delivered with that level of expertise to these people who potentially might have made a poor choice, or not quite expected their night to go the way it does. And, thankfully it's a small percentage of people at these festivals that end up in this situation. But like you said, it's a small number, but these are young people with the rest of their lives to live, all have families who are worried about them. Obviously, going out into the bush and having a good time. For most people that ends well, but for the ones that don't, I think they're really lucky to have you.
No worries. Thanks very much, Andy, for having me today.
Well, thanks for listening, and I hope that you enjoyed that episode. Like I said, I found that a fantastic interview. Martin is a mate and a colleague of mine, so there is that conflict, but I'm in full admiration for the work that he does in these quite austere, really challenging scenes that he goes out to with his team. And he's got a fantastic group of people that he works with, obviously, but they've really managed to save a lot of people's lives in these situations. These are, as I said, these are young people with families who would otherwise have come to grief and potentially died had it not been for Martin and his team. For those that are interested, they've actually published a case series about this very specific cohort of patients, and I'll put a link to it in the show notes and on the website and everywhere else. The article is called Characteristics, Presentation and Outcomes of Music Festival Patrons with Stimulant-Induced Serotonin Toxicity. It was in EMA in 2022. Like I said, I'll put a link to it. And amazingly, this very specific toxidrome and group of patients has, in the literature, a very high reported mortality rate, up to around 70% sometimes. And Martin's group have published this series of patients. It's around 40 patients, I think, with zero fatalities. So you can see that when you do this right and you learn how to do this right, you can really make a big difference to some young people's lives. So I think it's a fantastic article. This ties in also very nicely with our unit in Module 2 of the Tox course on MDMA toxicity, on sympathomimetic toxicity, and we go right down the rabbit hole on this in the course. And we'll teach you in great detail about how to recognise and manage these patients as well. So if you're interested, please go to etmonline.com and sign up for the Tox course. That's our new offering on ETM Online. Module 1 came out a few months ago, and Module 2 is coming out very shortly. This is we're recording this at the start of May. Hopefully in the next couple of weeks, Module 2, which is the recreational drug module, will be out soon. And like I said, if you're interested in this topic and want to know more about how to manage these patients in your ED, get onto the Tox course. Thanks very much, and we'll see you in the next episode.